that you may have that she'd be happy to answer. Justine, can you just unmute yourself and speak and share your screen?
Sure. It sounds like maybe I wasn't as late as I thought I was.
No, you're not.
Oh, okay.
We're late.
Okay, great. I managed to get lost dropping my dog off, so pretty good. And it's my best friend's house, so I don't know how I could do that. I just want to say that we're at Reach Medical, we're really grateful to the Catskills Addiction Coalition and its partners and sponsors for creating this community summit as part of our federal grant with R Corp to address harm reduction approaches to opiate use disorder and addictions. Just a little bit about Reach Medical. We're a low threshold medical practice that believes all individuals deserve respectful, equitable access to compassionate health care in a setting where they won't be stigmatized or judged based on drug use, even continued drug use, homelessness, or any other issue. Our providers and staff are well trained in delivering stigma-free care and know the importance of creating a safe, confidential space for our patients. We hope and we see that our patients come from all walks of life, and our services really, we do our best to meet their needs. And we thank you all, everyone who's online and in person, for participating in this work that I think we all feel is so important. Let me go ahead and share my screen. Let me just get this slideshow going first. And then nope, it's not going to let me do it that way. I thought it would. Hold on. I first have to share my screen, I think. Okay. And then let me start it. You guys are seeing it at least, right?
Yes.
Okay. So I want to thank Emily, who's actually on here. She's our new executive assistant at Reach. She is this powerful PowerPoint / she really can make things look great and help really add context. Emily comes to us from STAP, which you guys as part of the R Corp grant. And I also want to thank Val for everything that she's doing with R Corp. So the title of this talk is Stigmatizing Substance Use Disorder and Integrating Harm Reduction Practices. I think everyone can hear that I have a choir in the background of birds, so my life is a little bit chaotic. So I really want to talk a bit about what harm reduction is. According to the Harm Reduction Coalition, harm reduction is a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. Harm reduction is also a belief in it's also a movement for social justice built on a belief in and respect for the rights of people who use drugs. And I really feel, and I'll talk about a little bit why I've always felt this way, but even more now, as we all start to enter the world of harm reduction, especially folks who don't have real or have lived experience or face some of the inequities that other folks do, we have to remember that this movement is a movement that was built by the people who were affected. And as public health people getting into this field, we can often forget that we're sort of standing on the shoulders of others, and that it's really important to respect the true mission and really get to understand the true mission. Harm reduction seeks to develop strategies for change that are practical, humane, and effective for both service consumers and providers. And it doesn't include a specific set of strategies, but rather tries to meet users, or really anyone, where they're at. Probably people have seen this slide. Basically the circle of harm reduction includes respect, acceptance, empowerment, compassion, and collaboration. So for me, this means something like potentially opening a conversation with someone and really being okay saying, I know that for lots of people in the situation that you're in, potentially doing something like sexual transactions is something that might happen. Does this happen for you? Because it happens to lots of people. And I just want to make sure that if there's anything I can offer you to increase your safety while you're doing that work, I'm happy to do that. Also, it's respecting that people come from lots of trauma, being careful if you can kind of hear a pause in someone's voice, like, is this too traumatic? Maybe we can return to this question at another time, and respecting that lots of people use drugs that they don't have any issues with and any disorders with, but lots of people will continue to use drugs that they have a disorder with, and that's absolutely fine. My goal is to make sure or offer them things that might offer safety, like needles, syringes, and Narcan. So there's respect, acceptance, empowerment, compassion, and collaborating with people with what they want, not what I want for them. And I think we all know this, but we'll just sort of go over it again. People face lots of barriers to care, so it's stigma, and we're lucky enough at Reach to have built it or kind of not had it as part of the foundation, but when someone walks in, they're greeted no matter what their clothing looks like, no matter how many times they've been there, no matter if they've been hanging out in the hallway for 3 days, they're still greeted with, hey, how are you doing? You look great today. What's going on? Without the sort of classic, potentially walk into the emergency room and get, what are you doing here? Why are you back? I thought you saw the doctor yesterday. That's stigmatizing to anybody, but it happens more often to the folks that we see. And it really just sets off, just when you walk in, that sets off the whole bad tone for the day. Transportation is a huge issue for folks, a huge issue for me. I can't even get back from dropping my dog off, but in general, transportation is big. And we saw that with COVID, we were really able to serve more people because we were now allowed to do telemed, and that really opened the door to access for lots of folks who don't have something or access to care within 50 miles of their home. Housing, and just even to go off of that, if anyone's ever tried to get a Medicaid cab for someone out of county, it's impossible. You have to make sure that there isn't a provider with spots, whether or not that provider offers non-stigmatizing, respectful care. So the patient can't get to another county, even if they've already been to that provider and it hasn't gone well. Housing, as we all know, is a huge issue for folks. Insurance is a huge issue, especially for folks who are in that range of working 5 jobs, having a good amount of income or enough income to bypass what Medicaid will allow. And we all know about systemic discrimination for people who use drugs. And of course, there's racial and discrimination for LGBTQIA folks. All of this is a huge problem for people who need services, childcare, food, financial security needs. All of these things are big problems. So the forms of stigma, as we talked a little bit about, are stigma from individuals, self-stigma, and I feel like if anyone could raise their hand, I'll just raise mine. How many of us do self-stigma, waking up at 3 o'clock in the morning because we think we said the wrong thing, or we don't look the right way, we're not within the power circle of what looks great in America. We all have internalized stigma. Imagine what it feels like if you're using drugs and injecting them. It can be really horrific, and it can definitely cause you from seeking care. Institutional stigma, we really talked about, and stigma by association, just by being someone who uses drugs, other people might have a problem. Okay. So The effects of barriers on health outcomes. Barriers prevent individuals from seeking timely treatment for acute and chronic illnesses. That lack of timely treatment leads to poor health outcomes. They have increased distrust of the medical system, which we've all witnessed, especially with COVID vaccines right now, right? There's a good reason for people to distrust the medical system, especially for people of color when they've been used for testing in the past and not even been told about what the tests are about. Also, that much of the research hasn't been done on all populations in an equitable way. And higher healthcare and community costs can come from all of this in the future. So stigma really, basically, the fact that people feel stigma costs money. So, when we were talking about doing this talk, we had this conversation around recovery, which always throws me off because I don't really even know what the term recovery means. I think in America, lots of us feel that recovery means abstinence from, for someone who uses drugs or someone who has opiate use disorder, recovery means abstinence. And for me, I mean, if I'd in order to even use the term recovery, I'd really have to use a much broader definition, which is that people are doing the best that they can to take care of themselves given the situation that they're in, and that for me, it's even just having a tiny sense of compassion for oneself is recovery. And I'm not always sure that abstinence even means recovery. I think it just means that your system has gotten very good at telling you no, but it doesn't mean that that everything's okay for you. So I guess that for me, harm reduction is really a step, or is recovery. Syringe exchange programs are very much recovery. Low threshold medication for addiction treatment, being able to get healthcare and get behavioral health services are recovery. But when the system makes it so hard for people to get any sense of recovery, how much are we as healthcare providers or community-based organizations liable for the fact that we're keeping people from any sense of recovery? And now we're actually seeing that recovery, I mean, and really when I came into this, I guess now it's about 8 years ago, I didn't know anything about harm reduction. I was just fascinated by it, thought it really lifted a veil for me about what we do to people who don't fit our paradigm. It lifted the veil. When I looked at people who used opiates, it really felt very equivalent to what happened in the 80s with people who had HIV. There was this real sort of stigmatizing of those folks, and we've come a long way with that, although I think if you read the news, we're going backwards again in some states. But harm reduction is becoming mainstream. And for the people who are the people who built this movement, that's a really super scary process because is the movement going to be co-opted by providers who really don't believe in all of recovery or all of harm reduction? And I sort of stand with them as an ally and say, we really need to be careful as we're making progress in terms of harm reduction. So the progress that has been made is that Biden called for universal access to 3 medications to treat opiate use disorder, and those are buprenorphine, methadone, and naltrexone. I don't, by 2025, I don't actually personally as a clinician believe that naltrexone belongs in there. I believe it belongs in there if people want the access, but it actually has not been shown to save lives. But if by all means, if someone wants it and it works for them, I'll absolutely, low threshold, they can have it anytime. Now the administration is also calling for funding to purchase sterile syringes and fentanyl strips, which are necessary to provide evidence-based services to people who use drugs. But I don't know if anyone caught about a month or two ago, there was the idea of funding for pipes, and what came back was sort of a racialized dialogue about how we can't condone people smoking drugs. And so these are problematic. And now the ONDCP, which is the Office of National Drug Control, the Office of National Drug Control Policy, SAMHSA, the Substance Abuse Mental Health Association or Administration, and the Centers for Disease Control, all the federal groups convened for the first ever harm reduction summit, and a steering committee made up entirely of people of lived experience and treatment providers, because I was on that committee. We're working towards providing guidance and input on future administration harm reduction efforts. That's been a really difficult process because some of what goes on at these organizations is the criminalization of drugs. And so that's caused harm in itself. So we're really in this sort of super interesting time around harm reduction. I'll just give a little, I don't know, Diane, I just want to make sure there's time because I could stop here. I don't really need to talk about REACH.
About 30 seconds.
We talked a little bit about REACH. We basically treat anyone who needs care. I'll just kind of show the slides. We're integrated. We have a very big team approach. We're low threshold, we're convenient and accessible. One thing that's not on here is we make a really big effort to make sure that we are, that our staff itself is diverse, that we have a peer advisory board. We're working hard to get a really true peer workforce, which isn't always easy. And we know when we're doing these things that we focus much more on trust than we do on drug screens, diversion, and abstinence. That's all I've got.
Great. Justine, thank you. So, I'm going to ask, we have a few minutes for questions. If you have a question in the room, what I'd like you to do is come up and use the microphone. If you have a question in the chat, please post it in the chat and we'll read it out. Any questions in the room? You all get harm reduction. You're all on board with what she said. You guys all on board? They're laughing, Justine.
Why are they laughing?
Huh?
Why are they laughing?
Well, why? Yes, come on, Juan. Speak to it. Come on. Come on. Juan Figueroa, the sheriff of Ulster County.
Good morning.
I think he
What's
must
your
love
cord?
me. We're going to hang out. Juan, are we going to hang out?
By the way, I love your slide about stigma. I love your slide about stigma, and because it's something that goes all the way around. Just me standing here, I can look around the room and I can sense some folks that are uncomfortable with my presence. And I believe that the same thing applies to folks that have substance abuse disorder. And I find it fascinating the change that we've all had the last 3 years, in particular in law enforcement. You know, the question was about harm reduction, and I can tell you that, sure, I have some reservations of someone that's been in law enforcement for over 3 decades, mainly dealing in the business side of the narcotics field, working out of New York City, the biggest user city in the country. But I'm open-minded, and I know that we in law enforcement had to change the way we do things. And so I am not closed-minded when it comes to harm reduction, and I'm pretty open-minded about it. I think we have to take a chance on things if it's going to save lives, and because that's really what it's about, isn't it? It's about saving lives. And we all have our responsibilities, and we all have to have ownership, but in reality, it's about saving lives.
Thank you. Thank you.
You know what I find interesting, Juan, about, I don't know if you find this interesting, but what I find interesting, like now that I'm doing this work, is I'm more interested in what does the evidence show us than what is the paradigm we've been using before. So for example, we don't want any of our patients diverting medications, but that there's that great study by DePozo out of Vermont, where when they decriminalized buprenorphine, diversion overdose rates went down by 50%. And so I think it's important that we're looking at the laws as we have them, and also what the laws are in place because we think that something's going to happen. But when that thing doesn't happen that we thought was going to happen, we have to kind of be able to ask the questions. I mean, I love this sort of question as a whole. Like, we thought for a long time, I mean, to do the medical thing, we thought for a long time that women who had like pre-signs of cancer on their cervix, they all needed to get that taken care of before a certain age. And so all these women like had surgeries on their cervix, they couldn't have children. And then they stopped doing it, and they recognized that women, 95% of women will get rid of that virus that causes cancer, and they won't need all these procedures. And so I think it's interesting to ask the good questions and then test the opposite of what we think is going to be true and find out that it may not be true.
Thank you. Tiffany, anything online?
Yeah, because we have a statement that I think is really relevant.
Here, this isn't going to reach. Oh, well.
I can talk louder.
Talk loud.
So we have a statement in the chat from Stacy Green in Delaware that says, staff from the agencies at times have experienced feeling like harm reduction is enabling substance use, and it's difficult to explain. Harm reduction is meant to keep people safe, like a seatbelt in a car.
It is that, and it's also like, I mean, I guess most of the people in the audience, or some of the people in the audience, have kids, right? And is it true that when we hand out condoms and talk to kids about birth control, that we're condoning sex and more of them have sex? And the answer is, it actually doesn't pan out that way. So it seems to be true kind of across the board that when you're having conversations and talking with people about, you know, with your kids, even if you're going to use this thing, here's the pros and the cons. Here's what do you think you're going to do? I think, and here's how, if you're going to do this, like with my kids, which I think probably the police officers told their kids, I'm guessing, like, if you're going to, I don't care where you are, you're 23, you're completely drunk and some guy wants to take you off, you text me no matter what happens, and I will come get you anywhere, no matter what, because I don't want my kid dead, right? Or I don't want my kid to have some sort of thing happen to them. I think it's that. It's saying, if I want to, you know, if you're using drugs, I don't think anything I'm going to say is going to stop that from happening. But if you are using methamphetamines, I just really want to make sure that you have clean needles. Or if you're using methamphetamines and you're smoking it, you know what? I think I like that better than if you're injecting it. Because if you're smoking it, you're less likely to get an infection in your arm, right? Like, you're just kind of presenting the evidence and the availability of things that people can have that will keep them safer. And so I think it's important to look at what, in other words, the other great example would be, and I don't know if this is the correct term anymore, but for males having sex with males, I always thought that everyone used condoms. And then when I worked in college health, I found out that, at least anecdotally, people weren't using condoms. And I was like, you got to use a condom. And they're like, no one uses them. And I was like, what? Are you kidding me? No one uses them? We've got to stop this. And what am I going to do? I'm going to, like, everyone's been saying condoms forever, but no one's using them. So if no one's using them, we've got the wrong device, right? And so now we have PrEP and PEP, right? And that keeps people safe from getting HIV. Yes, like, we can say to kids, don't have sex, but they're having it. So what do? We try to talk to them about what would keep them safer when they do it. It's more about looking at human behavior seeing what people are doing despite our sort of, maybe even my own puritanical views, and saying, oh, how could I help them stay safe? My kids are now sick of me saying, I really want you to wait till you're 17 to use marijuana because the plasticity of your brain is going to be a problem if you do it. And they're like, we're not going to smoke pot, Mom. And I'm like, okay, if you're going to sneak out of the house. And they're like, we'll just tell you already, okay? Like, they're so sick of me telling them that it's okay to do things, that I think that it's almost like the opposite of dare, that they're just not going to do it because I've allowed everything to be possible. I don't know.
Well, Justine Waldman, I want to thank you so much for all of the fabulous work you're doing at Reach Medical and for being such a great partner with us. You're doing important work, and we're coming along on the harm reduction approach. I think it takes all of us to keep having these conversations to understand it more deeply. The person who is in my life who has an issue with substance use disorder was shooting heroin, and I would have conversations with him openly. I tried to keep that channel open and said, why don't you snort instead? And he is now in treatment. He has a job, he has a family, and he's feeling really good about his life. So I'm here to support the harm reduction approach, and thank you very much.
Thank you. And Juan, let's go to lunch or dinner sometime.
Ha ha! Juan, did you hear that? I'm sure he's here. Yeah, they're letting him know. Okay, thank you so much.
Thank you all for all that you're doing. Thank you so much.
Thank you. Yeah. So we're a little bit off schedule, so what I'm going to do is suggest we're going to be setting up the criminal justice panel, and while we do that, if you need to take a bathroom break to do that on Zoom, you can just go off mic, or whether you're muted anyway. But what we also want to encourage you to do is, if you have an idea for what the coalition and others, our partners, ought to be doing around prevention, treatment, and recovery services and harm reduction, please write it on the Post-it note and put it on the chart in that corner or on the back wall anytime during the day. If you're on Zoom, just put idea and then put it in there, and we'll capture that. So we're going to take a few minutes and let the criminal justice panel set up, and see you back here at 10:30. It's only 5 minutes.
So when they get ready, we can use the floor
Yep.
mic, but we also have the other one that we can hook up. So whoever the primary is.
That's Betsy. Yeah.
It's off right now.
Okay.
I can hold on to it for now.
It's Betsy, who was at dinner with us last night. She's the moderator.
Oh, okay.
I knew you wouldn't mind me putting you on the spot. I knew you wouldn't mind me and she wants to have lunch with you. She's up in Ithaca. In Ithaca. Yeah, she's good. She's really good. She's a physician, started Reach Medical. They're good. I will do that. And then when you and Sheriff Kaminsky have to leave, you'll just feel free. Thank you.